Thank you, Bruno. Thank you, Rob, for the kind introduction. And I want to say hello to everyone, people I know for now a while, and other that I'm meeting today, but I heard about you guys, and I'm very happy that we can do this webinar together. So Bruno took the words out of my mouth, because I was going to say that we represent the countries the most affected by the COVID. So maybe our experience is probably experience of the people busy with it. So first, I would like to thank Canon more generally for organizing this round table, because it's a very unusual that we do in this context such a round table, and we will be talking about the use of MR during and after the COVID period. So we all are almost at the end of the big shot, but we are going to the post-COVID period, which is not something so easy. So we would be very happy to share experiences of all of us to understand what is the position of MR, in which organ, what are we going to look at, what can we retrieve now from patients that have been affected, and how we even prepare the next hit, because we know that it might be possible that the virus is coming back. We don't know when, and maybe another one. So we have to be prepared. So after this, I want to say that Canon has put a lot of effort, as I can see, on the way to manage patients around the city. There has been already a webinar around the city, and now about MRI. And I think that it shows that Canon is very much looking for the health of the patients that are done on their magnet. So thank you for Canon to be so close to our preoccupation and the patient. So I don't want to talk too much. I'm a moderator, but I want to give directly, and I ask Professor Saba so to introduce himself. I'm myself from the University of Bordeaux. I haven't said that, but Professor Saba to just give us an overview of the situation in Italy more generally, even if your place was not as affected as other places in Italy. What has been how was the situation in Italy a few weeks ago, and in consideration to access to MR, for an example, and what is the future of the imaging in Italy after this crisis. So thank you, Professor Saba, to give us your advice.
It's a pleasure to be here. And thanks also to Canon to arrange and sponsor the production of this roundtable. I'm Luca Saba. I'm professor of radiology at the University of Cagliari, Italy. And I would like to start from the beginning of the story. Next, on the next two slides, please. And I would start to the beginning, because Italy was the first European country to face COVID-19 outbreak. In February 19, the first case of a patient admitted to the ECU for pneumonia without connection of the China was reported, and that it was the first patient zero for us. After 3 days, in February 22, we had in Catalonia, Lombardy, already 62 cases, and then we see an exponential growth of the outbreak in Italy. And luckily, after 3 months, now we see that the war is almost to be won. You can see here in Italy the case per million and the case per province. So there is a difference in terms of prevalence between the northern Italy and the central and south Italy. I'm speaking from Sardinia. And next slide, you see my island. I'm lucky, I'm here, Cagliari, and the prevalence of COVID was quite low here. However, obviously, we faced several cases. We had in Sardinia about 2,000 cases, And so we have a lot of activities and procedures regarding the cases procedure, and in particular to the MR. Let's move to the next slide. Okay, this is the story. Next. Next. Well, the pathophysiology of the COVID is not yet fully understood, but recent studies suggest that the virus gains into the host through the use of the angiotensin converting enzyme type 2 as its cellular receptor. And next. This is a membrane-bound monocarboxypeptidase, and it is represented in several human cells, in particular in the type 2 pneumocystis, but also in the kidneys, the cardiomyocytes, coronary pericytes, and also in the endothelial cells. Next. And also the presence of ACE2 receptor in the endothelial cells justify the attack into the vessels. In particular, there is endothelial dysfunction that leads to thrombosis. There is an enhanced permeability that creates a damage in the endothelial barrier, and so an invasion by the plaque inflammatory cells. And also the accumulation of inflammatory cells, neutrophils, myophyses, and lymphocytes determines the condition of vulnerable plaque that frequently trigger intraplaque hemorrhage. You see in these slides the normal plaque and a plaque with activity triggered by all those, this cascade. These blue dots are inflammatory cells. Next slide. So there are evidences that there is a microvascular damage. The COVID acts as a vascular virus, and so there is a vascular thrombosis within the vessel. This is a paper we published 1 month ago, and this is the demonstration in autopsy analysis published in the New England Journal of Medicine. Next slide. And this is the case of a lung of a patient died because of COVID. And if we look at the lung, we see the vessels. And if we look at the next slide, we can see the presence of microthrombi. So there is a series of activities that determine microthrombosis and endothelial damage, because it's not only a matter of presence of thrombosis, but also an infection. So there is an endothelitis with inflammatory cells. See next slides with a very interesting publication published in Lancet that show the endothelitis. These are microscope electronic pictures, and you see the virus within the endothelial vessels. Next slide. It's interesting to observe that there are differences according to the age, because in the pediatric, next, this virus determines in particular Kawasaki-like disease. So there is an effect in terms of inflammation, whereas the prothrombotic activity determines more frequently the presence of stroke. And it's interesting, it seems to be more frequent the presence of stroke in young patients. Next slide. If we look at the general vascular area, there is the lesion and the attack of myocardium, but the next speaker will speak about that. But if we speak about vessel imaging, we have also carotid artery, aorta, and the MR plays a key role in all these areas. In particular, if you speak, for example, in plaque imaging, MR is considered the gold standard for the detection and characterization of vulnerable plaque, and the same is for the aorta. Next slide. And these are some papers that better focus on these fields. Next. And this is an image of an intraplaque hemorrhage in a carotid artery obtained with magnetic resonance. Next slide. Interestingly, there is a high prevalence of neurological disease in patients affected by COVID-19. This is the results of a recently published meta-analysis, multi-center study published in Radiology. This is the Italian experience. And we found a prevalence of neurological disease that is about 22%. And the next slide, interesting, it's not only the presence of strokes, but we have found also more uncommon disease, in particular, yes, stroke, but others such as Guillain-Barré syndrome. So the infection activity and autoinflammation is present. Next slide. Other colleagues showed also that there is an increased prevalence of hemorrhage. So there is an imbalance between procoagulation, anticoagulation, likely in the COVID. And obviously, this type of pathology, cerebral microbleeds, can be found only by using magnetic resonance. We cannot identify such small leakage of blood by using CT. So for the diagnosis of this condition, the use of MRI is mandatory. Next slide. MRI is important not only for the first diagnosis of some types of pathology, but also for the assessment in the follow-up on patients affected by COVID. If we have to monitor the evolution of these pathologies in the vascular and in the neuro area, it's not possible to do if we not use MR, obviously, but I think we will speak about it in the next part of our discussion. We need to tailor our protocols and our procedures. Next slide. In conclusion, next, MR plays a key role in the diagnosis of pathologies COVID-related, in particular for the vascular and neuro area, for one simple reason, because some types of pathologies can be detected and characterized by using only MR. Thank you.
Thank you very much, Luca, for this presentation, and you focus on the neurologic aspect of the disease. I have a few questions before we move to our next speaker, but I have a few questions about physiopathology, because you really stress the vascular aspect, maybe because of the protein S to the receptors on the vascular bed, and you show on histopathology a lot of thrombi. So do you think that most of the cases you have had for neuro were related to stroke and to thrombosis, or is there something else like a direct infection with COVID on the neuronal cells or glial cells, or is there also inflammatory response that is overloading the body and the CNS? So what do you think is the most affecting problem?
Well, that is a great question. I'm not sure about what is the right answer. I think that the prothrombotic activity plays a fundamental role, in particular, because I cannot justify without that the involvement in young patients. So I think that there is a role for the prothrombotic actions. However, as you said, there is inflammatory actions. So maybe there is the concomitant action of both activities, pro-inflammatory and pro-thrombotic, and both determine the event. So I think that there are both sides acting.
Yeah, and overlapping, probably, yes.
Yeah.
And another question, this question I will ask to everyone. So listen to this question and try to understand, because to my feeling, there is a difference between patients that shows a severe disease and the one who have a mild disease. And how do you expect, and who would you target for the follow-up? People with a severe disease that now are better and went out of the hospital, of those who had a mild to moderate disease that most of them did not go to the hospital. So who do you expect to have brain lesions? All of them? Only few of them? Only the severe? This is the same question for the other organs. So, Professor Saba.
Thank you. Well, I agree with you. There are different grades of severity. Well, I will focus my attention in particular for patients with severe disease, because we see a low prevalence in patients with mild and intermediate severe, not severe disease. So our first experience suggests to put our fishes to patients with severe disease. They had neurological disease, pathologies, whereas if you had a mild COVID, or in some cases asymptomatic COVID, your body can react against the virus without problem. So that's my point.
So now I want to ask Professor Lima to introduce himself, but he's very renowned, so he doesn't need to introduce himself, but just a few words. And also the same thing, if you have a presentation you give, or if you want to give us an overview about the cardiac involvement, and also answer to the same question, who are going to be the patient to look at in the future? Okay, Professor Lima.
Good morning, and thank you very much, Professor Dousset and colleagues. I'm Joao Lima. I'm a cardiologist by training, but I work in the interface between cardiology and radiology at Hopkins. I have joint appointments. I am originally from Brazil, as Bruno mentioned, so I'm representing Brazil as well. I'm happy to, but since I've lived here in the United States for 30s, this is going to be the 40th year, so I'll be talking more about the U.S. experience. I don't have slides. I had thought that we are in the very middle of the epidemics here in Maryland specifically. As you know, the COVID epidemics in the U.S. began in the Seattle area, but it was New York that had the biggest impact and the burden first of the disease, and now it is spreading westward. And we are at Hopkins at the very I would say that we are a little bit past the peak, we hope, but with the reopening of some activities by our governor a week ago, we are seeing already a recrudescence, or in other words, hospitalizations that were going down have rebounded up, and to some degree, even though deaths, which you know, lag behind a couple of weeks, and we are still seeing a decrease in the number of deaths here in Maryland. Johns Hopkins in Maryland has 5 hospitals, and another one in Florida, which is a pediatric hospital. But the 5 hospitals in Maryland have acted much as a system. So we have seen the most severe patients in the central hospital and the younger, because we have the units for extracorporeal circulation, and this has been used, and actually now we are using it a little earlier than when we first started. So we have right now about 100 patients in the hospital, about 30 or so intubated under mechanical ventilation, and about 8 or so in extracorporeal in the extracorporeal unit, and this situation has been stable for the last, I would say 3 to 4 weeks. That has been our situation in the Hopkins system. So today I was just to give an update on how things are in our area, because Maryland right now is one of the hot spots, so to speak. Chicago and Maryland are one of the places where the epidemics are still quite intense. About 10% of the tests performed here are positive, we should be conceptualized as a metropolitan area that involves Baltimore, Washington, D.C., and the north of Virginia. And we are acting as such, and that's where the epicenter of the activities are. Now, leaving the acute epidemics for just a little bit and talking a little more specifically about imaging, the modality that has been used the most is chest X-ray. We have been following the American Radiology College of Radiology recommendation to use CT only in the patients who are more severely involved, and MR has been used only on patients who have cerebral changes. That's where the concentration of MR cases have been. And since we have had the younger population for the whole system, we have seen this only on the patients that have had microembolization for the brains, encephalitis, and I'm really thankful for Professor Saba for the review that delineates quite well, and as Professor Dousset emphasized, the cerebral syndrome. From a cardiac standpoint, which is my specific area, we have used echocardiograms that are performed in a portable situation, and we haven't seen as much left ventricular dysfunction, systolic dysfunction. We have seen more diastolic dysfunction. There is a syndrome very similar to myocarditis, to acute myocarditis. So if you look at the EKGs of these younger patients that are transferred to Hopkins, what you see is it is as if you're seeing epidemics of viral or Coxsackie myocarditis with very strange looking EKGs. And that appears to resolve as people recovers from the acute infection, but we don't really know. And we are looking at it as a myocarditic hit that we are very interested in the consequences. The pathologic studies that are available show that from China and also from Germany and from other places that have been involved in the epidemics shows myocarditic involvement more as edema than really a lot of cells, a lot of inflammatory cells, as you see in an acute myocarditis, say again by Coxsackie or by other. So it's an interesting, appears to be an interesting pathologic situation, but there's plenty of electrical disturbances. In other words, we realize that the myocardium is being hit. And if we follow the model of myocarditis, what we are afraid of would be a continuous immunologic reaction to that. and the appearance of damage later of the myocardium.
Okay, and yeah, another point is you have the EKG, so you can have the proportion of people and also enzymes, cardiac enzymes, so you can know the proportion of people with these disturbances, and maybe also compare to the results of MR. So does it make sense to scan only severe patients, or does it make sense to look at mild or moderate patients that maybe did not have much symptoms, but might have a scar and might have a pace troubles in the future? And so how do you position this screening of patients?
Yes, about less than 10% of the patients at Hopkins have had troponin elevations that are very worrisome. And those who went to the cath lab didn't really have, it was pretty clear that it was coming from the myocarditis. The ones who have had echocardiography, and I would say that, again, it falls around the 10% range. And those don't have a lot of systolic dysfunction, but they do have a lot of diastolic dysfunction. But a much greater percentage, and I can't give you the numbers exactly because we haven't done the EKG analysis in this much detail, have signs of myocardial involvement. So who would be the patients that would worry me? Would be those that had an EKG that looked very abnormal during their acute phase. And those abnormalities, again, are very different from one patient to another, just like an acute myocarditis. There are changes in ST segment elevation, depression. It looks like they're having an MI, or they have intraconduction abnormalities. All of that reflecting the fact that the myocardium is involved, but how much of that is going to translate in damage, we hope very little or not at all. But it's a lot of wishful thinking. We know that with this degree of damage, there will probably be consequences that we are very interested.
I have another question, then I will ask Luca and Josep to ask a question. But I have another question about the target of some people that might be followed because they have a profession where they are exposed to cardiac risk. And I'm taking one is obvious, is the sports people.
Yes.
Those people, for an example, in France, we are very concerned about our teams, our national teams, our local teams that are playing every Sunday, but we don't know, should they go play again, or who should be tested if they are positive? For an example, you get positively tested on the serum, so you may not have a very severe disease, but maybe mild symptoms. What to do with those patients? Should we check their myocardium with an MR? Is that only ECG, or enzymes? Enzymes may be too late. So what is your feeling about this population?
We are in the same, going through the same thoughts. And by the way, I really would like to hear from our other colleagues how cardiac involvement has played out in other places, because as I said, we have a perhaps a younger population than in other hospitals. At Hopkins, there has been more involvement of the myocardium, of the heart, with more coronary artery disease involvement. Now, back to your question, Professor Josep. I would say that it's an exercise stress test that would tell us who are the patients who should have MR. If patients have arrhythmia during effort, those would be the patients I would be worried about. That's the kind of protocol we are thinking for people who are involved in contact sports that require a lot of cardiac activity. And then for those, MRI to see if delayed enhancement is present. And again, is the presence of delayed enhancement that really tells us if the likelihood of sudden death is much greater than, and we should advise the player to then not play contact sports. It's in myocarditis due to other causes. This has been very difficult to enforce in some cases, as you know, but we know that the presence of scar, delayed enhancement caused by myocarditis is a very strong harbinger of sudden death in athletes that perform at a very high level. That's basically the protocol that we are planning to implement. But we are very interested in these MRI studies of people who survived to have a sample of how much we should expect to see. And I don't know if in other institutions, MRI studies on patients who survived COVID are being performed. I would be very interested to learn what is surfacing. I know there isn't much published yet, but I know everybody is interested in that.
Thank you, Joao. Professor Puig, Professor Saba, do you have questions or comments on to Professor Lima, or maybe comments on the situation for cardiac imaging in Italy and Spain? Go.
Well, thank you. I agree with Professor Lima that the situation is complex because there are not so many evidences to which is the best way to be followed. In Italy, it's interesting because we had a reduction of global myocardial infarction, and that is a curious event. Some think that the lockdown determined this effect. Regarding to who is the best candidates for MR in the cardiac analysis, I totally agree with Professor Lima. The stress test should be oriented our action. If the patient has a stress test positive, we should perform MR. So this is my 2 cents opinion regarding this point, but I'm very curious to see the literature that is coming out regarding this.
So thank you, Professor Lima, and we move to you, Professor Puig, and thank you for joining us. And so could you please introduce yourself and tell us what you think about, you know, MR in now and in the near future? How is the situation in Spain? And maybe you have some slides, so we will be happy to look at.
Yes. Thanks so much, Professor Dousset. I'm Josep Puig, so I'm working at this moment in two university hospitals here in Catalonia. I'm working in Girona and I'm working in Barcelona. In Barcelona, I'm working in the Comparative Center of Medicine in Badalona, in the metropolitan area of Barcelona, where Canon Medical Systems is the major techno partner in this center. So the center was opened in the last 8 months ago, more or less. So we don't have at this moment experience in humans because we are waiting for a resolution of the local government here in Catalonia to have the permission to put humans in the gallon, in the 3T gallon magnet. So I have prepared 3 slides about what I'm thinking about the vision of medical imaging market. This was the topic that Bruno told me to comment to you in this very interesting webinar. So the situation in Spain has been critical, as you follow in the news, because we have an horrible numbers in this pandemic. We are talking about 300,000 population infected. It represents 1 per 150 people here in the country. This is a lot. So we have a 10% of death. The mortality is horrible. 10%, more or less. Now the government are trying to make up in the numbers, but the numbers are around 10-12%. So it represents at this moment the 3rd country after Russia and UK here in Europe in terms of higher incidence. So my vision in this field, I try to summarize in this slide. You can see a lot of words, but I try to summarize the main concepts. I try to divide before, during, and after pandemic. Before, the market in imaging, we personally know that it represents a big business because we have the five promising and 5 useful tires in imaging. It means X-ray, CT, ultrasound, MRI, and nuclear medicine. We have this technology in the hospitals and the clinics and diagnostic private centers, research institutes. So it means big numbers in terms of business. Why this relation about the imaging, the market in imaging and the business? The direct key is the higher the demand in this market. Why we are lucky as a radiologists with this scenario? We are lucky because the population is increasing in aging. It means that the incidence of aging-associated disease will increase and are increasing at this moment. We are lucky because we are enjoying in our day-to-day about these technological advancements in imaging modalities. The technology in our specialty is really impressive, and all of this technology increments the business as well. So the number of medical imaging procedures probably after the pandemic will be increased as well. The medical system in general is awareness of the disease, and the demand of early diagnosis to use these tools as screening tools are also increased. It means that the demand in the market, suppose you can see here in the upper part of this left side, $25 billion. So it's really impressive. During the pandemic, what we are seeing during the pandemic, we are seeing different scenarios. Probably one target is the diagnosis, and the other is the follow-up or the monitorization, as the 2 previous colleagues comment. So we use mainly the X-ray, the CT, and ultrasound as well to do a screen, using them as screening tools for the mission of the patients in the level of care. That represent that these tools are very compensatory to study the suspected cases and then to manage these patients. It means that these 3 imaging modalities are the first in this context are the first line modalities to manage the patients. So the artificial intelligence is the other critical point that we are put a lot of investment and a lot of trust to go for these algorithms to help us to identify these patterns on the parenchymal lungs, in the vessels, also in the CT angios, and try to identify sooner these patients in the new pandemic, if this is the scenario in the future. So finally, it represents that probably we will see new imaging protocols, fast protocols. We will see, or we will have to develop or to merge these modalities and use them as very useful screening tools. Probably we will see new disease and clinical conditions. And finally, the departments of radiology in the worldwide will put more investment in terms to have this technology in the first line. So this is the overview that I would like to show you. If we go to for the next one, please. So what about the MRI? We have talked about some aspects or some issues in cardiac and vascular. My topic is neuro, so MRI will be useful and has been useful in terms of to see and to control the neurological disease in this patient. Remember that 50% of positive cases that we're seeing in the intensive care have some brain abnormalities. Professor Saba talked about this cortical microhemorrhage or subcortical microhemorrhage, this high signal and flare in the cortical sulci, different alterations in diffusion are very specific, but in the context when you see some of these findings, you have to think about possibly COVID involvement. So there are different, Professor Dousset talk about the role of acute stroke, or the more incidence of acute stroke in this kind of patients. The physiopathology are different from non-COVID patients. So probably the presentation of these patients in terms of imaging will be different. Now we are trying to do here in Spain very interesting and promising study. So we are trying to collect patients seen in the last 2.5 months before the mechanical thrombectomy, and trying to study if the thrombus composition or in the thrombus imaging is different in this kind of patients with respect patients without COVID. Probably we'll see thrombus with or lower density, probably the thrombus, the pattern of this stroke will be more peripheral or more superficial if we correlate with pulmonary embolism, independently that you are seeing a large vessel occlusion. Let's see what happens. And what about the role of the collateral circulation also? And what about the functional, the clinical functional outcome in these patients for a similar clinical severity, comparing these two main groups of patients with COVID and without COVID. There's another rare, but we have some cases about the acute necrotizing encephalopathy involving the thalamus, involving the deep nuclei. But if we go for the next one, so finally, just 1 minute for this. This could be, or could be sound like a future, but this is a study that we published 2 days ago, that we developed here in the province of Girona with the strong support of Canon. We performed more than 1,000 scanners using 1.5 ELN MRI in a population, the normal population, healthy population here in the province of Girona, over 50 years old until to 96 years old. So could this kind of imaging repository with this kind of imaging repository. You know, the UK Biobank, you know, other cohorts of thousands of participants as well in the heart of Europe, in Germany. Do you think that this kind we can study? In fact, we can study the whole body of the participants. You see the protocol here in this slide. So we can use the artificial intelligence to go into this image, into this data, and to provide us some vulnerable cases for the next pandemic situation. You can see the vessels. This is an angio without contrast. Obviously, this is two cameras in the heart imaging in the middle of the slide without contrast, because you cannot support the administration of contrast in healthy people in one population MRI study. But probably using all this kind of information, we can identify different phenotyping risky profiles. We have this information. We will see what is the result, but could be interesting to study this normal, between brackets, this normal imaging before the pandemic, to have more information for the next one in the population. So this is my slides, and I will be more than happy to. I'm very happy to participate in this webinar next to you, and has been really interesting.
Thank you very much, Professor Puig, for this overview about. If I understand well from your first slide, which is very interesting, you show how much in the acute situation some of the techniques were the most useful, the most, I would say, practicable at the bed of the patient or adaptable to the patient. And that, I think, is a very important point. The second is, and I think from your last slide, what you show is a way to scan the patients with MR exactly in the same way that we do with a CT. We do the CT from the hair to the toes, and we do, you know, some organs one by one separately. So to introduce, I mean, the discussion now, because I think we are running a little bit out of time, unless you have half an hour in front of you. If you do so, we can go on. Otherwise, we go directly to the round table. So do you have a little bit of time, or each of you?
Yes.
Of course.
Okay, so in such case, I'm going to make my presentation. It will be short because you already talked about many things, especially my specialty is neuroradiology. So it has been already covered, but I will show you some slides, and then I would like to have the discussion, and it was already open during my questions, but about how to scan and who to scan with MR. In the post-COVID period. So those are the questions. So this is to show you that we reopen our research activity. Now we have masks. We did the same photos before with some of the people are here, but now we have a mask. But you can see volunteers or patients that we are doing now on our device at Bordeaux University. Next. I was interested to look at two studies that have been done. One in Wuhan, with one of the earliest published study in the American JAMA, and it was done by a team that I personally visited in Wuhan several years ago. So and they produced this paper on the 214 patients. And what they show is that around 36% of people had a neurologic manifestation, and they include dizziness and headache. And you can see 13% of people were complaining headache. And smell was was impaired in 5% of the people. And finally, on those people that had a severe disease, they had only 2.8% of acute cerebrovascular disease, which is pretty low. I compare with a paper that has been recently published in the Journal of International Medicine about 1,400 patients in Europe coming from all our countries actually. And interestingly, the headache was 70% of the population. So it shows that this is the number one of the symptoms in the patients. And even more than fever, that was only 50%. So it's interesting. The population is different. Those are mild to moderate patients with COVID. The other study from Wuhan was with the severe patients. And the smell impairment is 70%. So you can see also a big difference. And so there are many questions about those differences, maybe because Asian population are different than the European population, so symptoms are maybe different for that. Maybe the ACE receptors are different according to the different type of population. So there are many questions about that. Besides this, next slide, in fact, there have been several papers that show, and a lot of single cases that show abnormalities in the brain. So here I summarize what has been found. And you can see that there are many different types of situations and in few cases. So it makes me feel that the CNS involvement is more like a side effect of the general involvement. And this is my feeling. And I don't feel that the virus is really targeting the CNS directly because you have all those imaging and those different kind of images on a low number of people. Next slides. So I can show you now, it's almost the same than were shown by Luca. Before, there has been cases reported with small infarct where the arrows are, or on the star in the cerebellum. Next slide. And of course, acute thrombosis, but when you see the thrombosis of the basilar artery here, concomitantly, there were thrombosis in many organs, including the pulmonary, including in the aorta wall, and also in the kidneys. So you think it's a more general process that is affecting the brain. Next slide. Yeah, and also T2 hyperintensities have been shown in patients in ICU, but their pulmonary conditions may account for the low rate of oxygenation in the deep part of the brain. So is that specific, or is this more likely related to the situation in ICU? Next slide. Again, there are cases of suspected meningitis or encephalitis, but it's difficult to make sure those cases are a direct encephalitis or a reaction to encephalitis or even a small stroke. So those has to be confirmed. Next slide. And also maybe ADM, which is a reaction to the virus that usually happens several days, usually a week, at least a week after the infection. And there has been cases showing that, but again, this is not a direct involvement by the virus. Next slide. And of course, the cytokine storm that can bring the acute hemorrhagic necrotizing encephalitis, but usually those patients have cardiac problems, pulmonary problems, and SARS, and etc. Next slide. So in Bordeaux, we had those cases in ICU on the left with probably ischemic condition. and due to hypoxemia. And we had one case of maybe DM or thrombosis of small vessels. Next slide. So to me, what I see is that for the neuro, we don't have only one or two or three single disease. We have a spread of different conditions. And for that, I've proposed, and we have been talking with the Canon team about which sequences to do in the acute phase, and maybe which sequences to use in the subacute and chronic phase. And you can see that we move from the one which are really directed to the disease, but we still keep some of them that are the key sequences for neuroimaging, but also optional sequences for research, because we don't know exactly what is going to happen in the brain of the patients. And so I think that 3DT1, for an example, is interesting to look at brain atrophy. And I join what you said, Josep, to follow a group of people over time, and optional sequences for DTI, because maybe there are some affection in the white matter, QSM for the iron deposition, and double diffusion encoding to have more quantitative data about the diffusion. Now, I would like to move, because I don't want to be too long. I would like to move to a very key question that we have to ask ourselves about the use of MRI in the post-COVID period, and especially what kind of imaging protocol we can put together. Is there a place, as Josep you show, for total body imaging with MRI, or is it too long to perform on a patient, or can we use minimal acquisition for each of the organ? And what are the organs that should be targeted, and which patients? And this is a very important question I'm asking always myself. And I already asked you the question, severe ones that now are out of the hospital, or mild to moderate one, because we want to screen them to make sure that they don't have a cardiac scare, that they don't have a pulmonary involvement, that they don't have sequela of the or in the brain or in the kidney. So I leave this question open. So please give the advice and ask a question if you wish to the other one. So please go on. I don't know who wants to speak first.
Okay. I can begin. One of the problems we are having is to select controls for comparing patients who were exposed to COVID, and being able to be sure that the alterations we are seeing were induced by COVID. And I think Vincent showed in a marvelous way how this is also going to be a challenge in the might be a challenge in the brains as well. So for those, I would like to ask Dr. Puig, Professor Puig, what do you think the value? Because we think that perhaps these databases of normal individuals, or individuals that were healthy in the community, will be very helpful for comparing with individuals that were involved by COVID. What are your thoughts about that?
Yes, this is a very, very, very interesting, and we have to solve, if we want to perform one promising study in this issue. This is a critical methodological point of view, Professor Lima. I personally agree that we have to go for the normal cohort of participants, not patients, of participants. Yeah. We have to go before the pandemic. We have to go for this kind of data sets, Asian Imagenomics Study, UK Biobank, German cohorts. We have to go for the period of before the pandemic, because if not, the confusional factors that we will have in the statistical analysis will be crazy. Because really, we don't know if the population is or not infected at this moment. And what about the tools to measure this immunity? When you have one patient target with the level of infected, you can have the confirmation of this case. But to put another case, if we plan case control, if you put this control without this kind of lab tools, probably we will have serious critical methodological problems. We have to study for the controls. We have to study people examined before the pandemic. This is my feeling. But another issue is the protocol. Merge the protocol. Now, if we develop one interesting protocol, probably less than 1 hour examination. No, less than 1 hour, because we can study the whole body. But for the COVID,
1 hour is a limit.
Yeah, 1 hour is the limit. Completely agree, fully agree. But now we have to administrate contrast, mainly for the vascular and for the health, to evaluate the cardiac morphology and the cardiac function. But in this kind of normal cohorts that we have at this moment, when we try to study the whole body MRI in a population-based study, we do not administrate contrast. So this will be one limitation. But my feeling is I prefer to have this retrospective recruited cohort than to study one theoretically normal patient, non-COVID. Because if not, when we submit this kind of study to a top-level journal, methods always, or 80% of the rejections are due to problems in methodology, and this could be a serious problem. Yeah, and about the protocol that you, Professor Dousset, present, I think this protocol covers the main areas in the brain, but probably if could be possible, I would like to introduce one resting state examination, mainly to compare the evolution, the follow-up, because probably this kind of virus affect the whole brain, probably. So we can see some alterations in some targets, the nuclei, in the basal ganglia, the cortex, but probably if we consider independently the viral invasion or one more autoimmunitary reaction, probably in both the scenarios, the brain is affected as a whole. So the alteration of functional networks correlating with cognitive function after the COVID, in a similar way, is completely different, but in a similar way, like the mild brain trauma injury. You don't see nothing, or a slight imaging, slight findings in imaging in the baseline, but the 10 or 20% of the people have some kind of disturbance several months after the initial injury. So probably here in the COVID, this could be one possible scenario. And my feeling is that functional networks could be help us to study this kind of affection if we consider the brain as one entity organ.
my conclusion is an open conclusion because
Yes.
I think that based on what we said, it seemed that it would be interesting to set up a protocol, first a protocol with a rationale behind each of the sequences. We heard, for an example, that gadolinium was probably compulsory for the heart, maybe interesting also for the brain anyway. So we also understood that maybe brain and heart and vascular bed are the first target. Maybe try to do a protocol that is below 1 hour, and also discuss between us, maybe other teams, so according to what Canon wants, but maybe try to see what is the rationale for scanning and which patients should be scanned, should be followed. Either those are mild, moderate, severe people, patients that, I don't know. So maybe we have to discuss that and go fast, because there are also competitors. We are not the only one thinking about looking at the brain and the heart of COVID patients. So I propose that in the next days, to go fast, we really discuss through the email and other means to have a protocol of research for with the Canon technology.
Yes.
Is that okay?
That would be fantastic. Yeah.
Yes, sounds great.
Okay. So any word of conclusion, each of you? Is that fine?
I think you perfectly conclude all the scenario, Professor Dousset. Excellent moderator.
Thank you very much, Josep. Luca, any word?
Thank you. It was a great discussion, and I'm very happy to be here and looking forward to see the outcome of our discussion with the protocols and cooperation among them. Thank you.
Right.
Thanks a lot.
Thank you. Joao, the last words for Joao.
I would like to say thank you, Vincent. You did a fantastic job and summarized it quite well. And I'm very interested in remaining very engaged with this group and defining what we are going to be doing next. Thank you.